So, thank you. All right. So I have been through the participant profile, and I have a fair sense of who's in this room. But what I really like to do is to just check in with everybody at the start of the session. In one word, how are you feeling? And you can just put in one word. You don't have to put in a sentence. If you prefer to put in a number, you can put in a number, 10 being good, 1 being bad. Where on 1 to 10 are you? So that also gives me a sense of what sort of an emotional space I'm walking into with all of you. Okay. Oh, I'd like to see those 10s. 7 is honest, good. All right. Whether it's words, whether it's numbers, whatever you prefer, please put in something in the chat box. And I know we don't have the time for all of us to introduce ourselves to one another, but I'm hoping that through our interactions over the next few weeks, we all get to know each other a little bit. I know in the previous batches, people have formed pretty strong friendships and connections with one another. So I'm hoping that with this batch too, that we're able to achieve some of that. Okay, so apart from the professional credentials, I'll tell you one more thing about myself. I've been in palliative care now for 23 years, and I'm not a medically trained person. And I honestly believe that palliative care is body. Everyone has a place and a role in it. And what we are attempting to do in the next few sessions with all of you is to really orient you to the landscape of palliative care in India as we experience it today. Okay, we are not going to go into very deep skill building, perhaps just in maybe a few modules where we'll be talking about communication and things like that. But by and large, this is for all of us to get on the same page in terms of what palliative care looks like today, what are some of the concerns that we're facing as a community, and where we hope that people like yourselves can join in. I'd also like to mention some little bit of housekeeping rules that would apply not just to this session, but to all the sessions coming after this as well. Please use the chat box. Okay, if you have any questions, if you have any comments, put it in the chat box. That's what Arya and Sangeeta are here for, to help me coordinate and respond to questions. If you have comments and reflections, I'm happy to receive those as well. Sometimes I find that, and this is our 11th batch, sometimes I find that some of the topics we discuss cause emotional responses in people, especially because we're talking about illness, caregiving, about bereavement, we're talking about death. So if it come up for you, please feel free to share. But if it's something very personal, I will request that you save it for the end of the session. The reason I say that is not because I don't want to hear from you. It's because when someone shares something meaningful and personal, we have to stop. All right, sorry. I've had fabulous internet connection for the last few days. So I was saying that if you have any personal things to share, please save it for towards the second half of the session so that we can give it the attention and the time that without, delaying the flow of the session too much. Okay, so let's get into it. Can I just, by show of hands or using the chat box, how many of you here are familiar with palliative care? If you are, then give me a thumbs up with your with the reaction button at the bottom of your screen, or maybe just give me a thumbs up with your cameras on. Okay.
Some thumbs up
1,
are
2,
coming.
3.
Akansha Singh, and some chats are coming also. Dr. Payag, Seema Khan. Everyone is familiar in the palliative care.
So, Sangeet, we have about 31 people in the room. How many yeses are we seeing? 10? More than 10?
Yes, ma'am. Now it's more than 10.
Okay, but not more than 20?
No.
Okay, so safe to say that still majority of the crowd is not familiar. So for those of you who are familiar with palliative care, you might find things here that you already know. In which case, I will very warmly welcome your additions and insights. For those of you who don't know, like I said, please feel free to ask questions, and we will try and respond to the questions as we take short breaks between slides. Okay, so I'm going to try and share my screen now. And Arya, I'm going to count on you to let me know if something is not working, and then you can share from your side.
Okay,
Can you see my screen?
Yes, ma'am. Now it's visible.
Okay, I'm going to turn off my video now so that my bandwidth is better. All right. Okay, so before we define palliative care, we need to go back to the basic healthcare. And why do I say that? Because as an organization, like Sangeet said in our introduction, we're trying to integrate palliative care with healthcare regime. Because so far, one thing we need to understand about healthcare. Health is not only the absence of disease or infirmity, it is the presence of physical, social, and mental. Let's read that again. Health is not the absence of
Ma'am,
infirmity.
your voice
It
is
is the
breaking.
presence. Sorry, I'm very sorry. Is it better now?
It's better now, ma'am.
Okay. Yeah, so health is not only the absence of disease or infirmity, it is the presence of physical, social, and mental well-being. Let me ask you all, in the way our healthcare system works these days, are we focusing on the first or are we focusing on the second sentence? What is our healthcare system focusing on most? The first sentence, Parag says, yeah. Okay, so just going by the first few responses, we all agree. Okay, so what we're really practicing today as a professional healthcare system is not full healthcare because we're not looking at well-being. Now, I'm going to show you this really sad statistic. Okay, it's a moving statistic. Why am I showing you a National Crime Records Bureau of India stat? In 2014, not approximately, 26,426 people in India suffering from various ailments, including cancer, HIV, and paralysis, chose to end their lives in 2013. This is a 2014 NCRB report. It was the second highest cause for suicide in India. Okay, being unwell. 2021, things hadn't changed much. Death by suicide reached an all-time high in 2021. And between 2020 and 2021, there was an increase of 7% of deaths. Now, what does the statistic tell you? There is no study that corroborates serious health-related suffering with suicide in India. But this is the statistic. So let me stop sharing my screen for a second because I want to know, what does this evoke in you, these statistics? What does it tell you? What are some of the things that come up for you? Why is this statistic there? Use the chat. You can unmute if you like. What do you think is going on there?
Financial toxicity for the chronic illnesses, leading people
Yes.
to take the most.
Yes.
rigorous
Thank you. Yeah. Thank you. That's a very good point.
Dr.
Along with physical. Yeah.
Dr. Payal said, along with physical issues, emotional issues are rising.
Okay. What else could be linking the two statistics? Pain and suffering are not addressed. Okay. Coping. Nanda, can you be a little bit more elaborate with that? Yeah. Dhwani? Coping with suffering, not enough care services. Okay. Emotional concerns. All right, we get the picture. Now, I'm just going to go back to sharing my screen. Like I said, there are no studies really corroborating the two. But if we apply our minds, we know there are several reasons why people with serious health-related suffering could be choosing suicide, right? And as we go along, we're going to explore this a little bit. There's something called the Quality of Death Index, okay? The Economist Intelligence Unit was commissioned by the Lien Foundation. Lien Foundation is an organization in Singapore. And they basically ranked different countries on the quality of death. Now, there were about 24 indicators across 4 categories or something like that. And the indicators included things like adequate palliative care, infrastructure, medicines, trained healthcare workers, etc. And based on all these factors, how did people die in different countries? So in 2010, when they first did this study, India came 39 out of 40 countries. That means people were dying very badly in India. It was the second worst country to die in. The studies conducted. 2015, we came 67 out of 80 over here. 2021, 59 out of 81. So we're crawling up that ranking. If you take a close look, all the countries at the bottom are global south countries, developing countries. It's the high-income countries that are up here. I'm not going to go into that right now, but I want you to bear that idea in your mind, okay? Okay. Now, another reason which was also pointed out is financial toxicity. So in India, 55 million Indians are pushed below the poverty line every year because of catastrophic out-of-pocket healthcare expenditure. If you're sick in India, we don't have the kind of security and insurance that a lot of high-income countries have. You have to pay out of your own pocket. And that means 55 million Indians are being impoverished by the healthcare system. So a system that is supposed to reduce suffering is inflicting more suffering. And like you said, that could be a reason why people are choosing not to be a burden on their families. And that could be related to the suicide statistic. This is conjecture on my part, but it seems to, be logical. Now, there's something called the Astana Declaration. All of you have heard of universal health coverage. Yeah, we keep hearing about UHC, Sustainable Development Goals, etc. So Astana is in Kazakhstan, and this is where a declaration was made in 2018, where they said that universal health coverage should be something that we all aspire to. And what 2 things I'm picking out of what they said was quality healthcare should reach people where they are, when they need it, at an affordable cost. So you see the words I've highlighted: quality. It should reach them when they need, where they are, when they need it, at an affordable cost. Health for all has to be health with all. And you have to include people in the designing and controlling of health systems. If you have diabetes, if you have a chronic condition, you should have a say in how you should be treated. And it should be, the treatment options available to you should be affordable, it should be of good quality, and you should get it wherever you need it. Again, I'm going to ask you to compare it to our healthcare system as it currently is. Okay. Now, I'm going to go back to a story from 2016. This was in the Hindu, where a 30-year-old man, basically, he wanted to have his son euthanized. He moved the High Court and, the district court, and then he asked for his son to be euthanized because he said his son was in so much pain that the parents couldn't bear it. Okay, child was 4 years old. So this came out in the papers, and palliative care experts from across the south of India, we tried to locate this child. And we finally found him in a hospital in Bangalore in the ICU. Now, I want you to know that this child had been to every major city in South India, from Madras to Hyderabad. And in Hyderabad, ironically, he was a stone's throw away from, at the time, one of the only children's palliative care services in the country. Like, if he had just walked across, he would have made it, but he was not referred to it. They had crisscrossed South India, finally landed up in an ICU in Bangalore where the child was bleeding out. And a social worker got on a bus from Hyderabad with a prescription for opioids for pain relief from a pediatric palliative care physician, came across to Bangalore and was denied entry into the hospital. The child died in excruciating pain. This is 2016. Did you read the papers 2 days ago? This is from day before yesterday. Oh, sorry, yesterday morning. Sorry. Yesterday morning, Times of India. Elderly parents ask the Supreme Court of India to allow the removal of the Ryle's tube for their son who has been in a vegetative state for 11 years. He's a 30-year-old man who's been in a vegetative state for 11 years. And the Supreme Court has rejected it, saying, no, it's passive euthanasia. And passive euthanasia does not allow the Ryle's tube to be removed. It allows for life-sustaining treatment to be removed. I mean, this is an ongoing thing. An op-ed has appeared today, written by 3 of our palliative care experts and critical care and neurology. Dr. Roop Gursahani, Dr. R.K. Mani, and Dr. Nagesh Sima have responded to this, and a series of these op-eds are going to come out. But why am I showing you these two stories? I'm going to stop sharing my screen because I want to just pause here. Story from 2016, parents wanting to euthanize their 4-year-old child. Story from 2024, parents wanting to remove the Ryle's tube from their 30-year-old son who's been in a vegetative state for 11 years. What's wrong in this picture? What's going on here that is so, it's not sitting right with you? Is there something that is missing that could have been done in both cases? Policies. There are policies. Shanmugapriya, there are policies. What is missing? What is missing in these two? Support.
Compassion.
Compassion. Prompt action. Neither patient. Sorry?
So absence in addressing the quality of life of the patient as well as the caregivers.
So what you're saying to me is what was missing in both is palliative care. Neither patient received palliative care. If you're talking about compassion, you're talking about, support, you're talking about paying attention to the quality of life. These are all the tenets of palliative care. And 12 years apart, it's missing in both cases. Okay, so we'll come back to these stories a little later, but I'm just telling you that this is current. If you look at the newspapers from yesterday, you will find the story everywhere. All right. So now let's ask the question, what is palliative? And there are many myths about palliative care. What are some of the ideas that people have about palliative care that may not necessarily be true? What is palliative care? Let me start you off. A lot of people believe that palliative care is only for people dying of cancer. A lot of people believe that. People with cancer and people who are dying of cancer. Yeah. And they don't, yes, thank you. That's what, end of life and only for cancer. That is the most pervasive belief people have. And therefore, people with other conditions or people with early stage cancer say, not for me. I don't want palliative care. It's for people who are dying. So, but what we really want to drive home is that palliative care can benefit patients and their families from the time of diagnosis of any life-limiting or life-threatening condition. From the time of diagnosis. Okay, life-limiting. What is life-limiting? Life-threatening, we know. Terminal disease, incurable disease. Life-limiting? Life-limiting could be a condition that we have that is not going to kill us in the near future, but it limits us from engaging with life fully. Okay, it could be a spinal cord trauma. It could be, it could be a chronic respiratory issue. It could be a various number of things that really, yes, thank you. Motor neuron disease and so on. And so anybody with any of these conditions, right from the start, would be a candidate for palliative care. And that is something we all need to very clearly articulate to people around us. Palliative care means giving up hope. I'm not ready for palliative care yet. I've heard this from so many patients. It's not time. It's not time for what? It's not time. No. If I go for palliative care, if I suggest palliative care to my father, he'll think I'm giving him. So these are myths that people have that prevent their family members from receiving the care that they might benefit from. Now, when it comes to hope, we have to make the distinction between hope and wishful thinking. A lot of the times, what we think of as hope is actually wishful thinking. Someone with fourth stage, fourth grade cancer for a full recovery, is that hope or is that wishful thinking? It's wishful thinking. We want it to be true. And we often disguise it as hope. And then we say, no, now we're going to keep on doing these treatments because we have hope. We in palliative care, we help make the distinction between realistic hope and wishful thinking. That does not mean that we're giving up on the person. It means our hope is that the person will be comfortable, they'll be able to engage with their families. We try and elicit their wishes so that they can actually work towards, achieving short-term, mid-term goals, which will also give them some amount of satisfaction. And also focusing on what the person values rather than rushing off to the hospital all the time. People believe that palliative care hastens death. Okay. Actually, what it does is it provides comfort and the best quality of life, no matter how much time is left. And actually, there are studies that show if good palliative care is done, people actually, they live longer than their expectancy. Because it does bring about a sense of well-being and to a certain extent, a sense of relaxing into their bodies, bringing down their stress, anxiety levels, etc. And people actually sometimes do well once they have received palliative care. Okay. I'm reading your comments as well, Payal. Thank you very much. Okay. A lot of people believe that pain is a part of serious illness and dying. If the person is in pain, he's got cancer, of course he's going to be in pain. Now, let me just stop sharing for a second here because I think I need to just also bring to your attention that pain was taught in your 5-year MBBS undergrad curriculum. It was taught till 2019. It was taught for a grand total of 1 hour. Pain management, physical pain management, okay? And it was a non-examinable subject. What does that mean? There are questions in the exam paper for pain management. So what happens then? As a medical student, I have so much to study. I'm not going to study something that is not even going to be a question in the question paper. So it just gives the impression that, okay, physical pain management is not important. Therefore, a lot of doctors, till very recently, were not actually giving pain management the kind of attention that it deserved. And there are also other reasons for it. I won't get into that at the moment. Now, in 2019, the then Medical Council of India said, no, we will introduce end-of-life care, palliative care, different aspects into this 5-year undergraduate medical curriculum, which is great. So we actually help them develop the modules. Now, the question is, in the over, I don't know how many 100 colleges in India, who's going to teach this subject? Because the teachers were not taught it themselves. So now we're doing a training of trainers, and it's going to take another few years before this actually really seeps into the medical education system. There you go. I don't remember any pain management topic in my dental studies. There you go. Yeah, exactly. So the easier thing then to say is pain is part of the disease. Just bear it. It's part and parcel of the illness. But what we're here to say is that pain doesn't have to be part of an illness and dying. There are many ways that it can be alleviated as long as you are taught how to do it. Morphine is administered to hasten death. Now, morphine, everybody is scared of the word morphine, or majority of the people are scared of the word morphine. And a lot of people think that it actually hastens death. It does not. Appropriate doses of morphine keeps patients comfortable and actually might have, and will have no impact on mortality. And a lot of people believe that taking pain medication in palliative care will lead to addiction. That's an I hear very often. Let's go into the opioids yet. We'll manage it with other drugs because opioids, once you start, you can't stop. That's not true. People who have been trained in titrating and dispensing and prescribing morphine and other opioids will use doses that are not going to cause any amount of addiction. And we have enough evidence and studies to back that up. Okay. Now, a little bit of a busy slide, but palliative care, this is a mouthful, I always have a hard time going through this particular definition, is the active holistic care of individuals across all ages with serious health-related suffering due to severe illness, and especially of those near the end of life. And we are aiming to improve the quality of life of patients, families, and caregivers. Now, if you look at this diagram, here, this is where palliative care should start. And yes, it grows into sharper focus as we get towards end of life and death and then bereavement care. We are the only ones there after bereavement. So this is typically how it should go, how it should look. But unfortunately, what happens is palliative care teams are brought in here. When there hasn't been a chance to really establish a bond with the family, suddenly there's a transfer of medical teams. There's no explanation given about palliative care. And so it's a very jarring experience for the family also, who then feels abandoned by the healthcare system because they're saying, there's nothing more we can do for you. Here, these people will take care of everything from here on. But ideally, both teams should work together like this. Okay, and this is again a bit of a busy slide, but it also tells you what can be done. Now, life-limiting, life-threatening condition is over here. There's lots of stuff we can do. So psychosocial support, maximizing community support. There's palliative surgery, palliative chemotherapy, lots of things, symptom control. As a person enters end of life, which is weeks to months to live, then we start thinking about other kinds of symptom management, ongoing medical treatment as appropriate, spiritual care, etc. And as we go into terminal care, where there's days or hours to live, and people start actively dying, then we start paying attention also to the families, if they're ready or not, what sort of coping mechanisms are in place for them, and of course, symptom control for the family, for the patient itself. Now, by and large, and this is an image we came up with, by and large, people think of palliative care as end-of-life care. But what palliative care is so much more. And end-of-life care is a part of it, but it's only one part of it. And we're looking at community support, we're looking at pain relief, symptom management. It's an interdisciplinary care. We're getting the whole team to work with you. There's psychosocial and spiritual care, preparing the family and the patient for death, and always family and caregiver support and restoration of dignity. And why empathetic communication is the sun and the sky is because that has to really overarch everything that we do. Okay? Now, in palliative care, we have this idea of total pain. And total pain is basically when someone tells us they're experiencing physical pain, we have to remember that their physical pain is impacted by their life circumstances. So let's do a little thought experiment here, shall we? Everybody, I'm not asking you to think about a migraine level headache, okay? I'm asking you to think about just like a dehydration headache. And imagine that you have this headache. It's on a Sunday morning. You don't have to go to work. And there is someone at home to look after you, maybe give you a little head massage or a foot massage, make you a cup of tea or some, soup or something, and you can go back and take a nap. There are no deadlines, there's nothing. On a scale of 1 to 10, 10 being the worst kind of pain, 1 being little bit of pain, where will you rate that particular headache? Please use the chat. So I'm seeing mostly in the middle numbers, right? 3, 5, 3, or on the lesser side. Okay. Okay, now guys, same headache. Monday morning, you're late to work. You've missed a deadline. Your child has vomited his or her breakfast. You had an argument with your parent or your spouse, and on the way to work, you've had a flat tire. Same headache. What's the score now? 10, 8, 7. And this is an imaginary headache. And you already know the difference in how you'll experience that headache, right? That's total pain. That right there is total pain. Now take this and 100x it with people who have severe illness and severe pain. They have to mortgage their house to pay for their bills. They have to make their children drop out of school so that that tuition fee can be used for chemotherapy. They have to give up their jobs to stay at home and look after their loved ones. Can you imagine that pain? Now, when I take you back to that suicide statistic, does something else click into place? Why someone might feel depressed or why someone might feel completely hopeless. So we need to always, when we look at the person, every human being exists within a context. No human is just going to be a repository of disease and illness. We're not treating just cancer. We're not treating just blood pressure. We're not treating just a headache. We're treating the person who exists within the landscape that they inhabit. Okay, so that is total pain. And so in palliative care, what we are looking at is total pain. And here's what we say, that illness-related suffering is much more than just physical distress. It has a physical component, it has a psychological component, it has a spiritual component, and a socio-economic component. Okay, and we have to assess, that's why palliative care has an interdisciplinary team. And in one of the modules coming up, you will be taken through what an interdisciplinary team looks like and why it's so important that this entire team works together. If you want to alleviate someone's total pain, you cannot just take care of the medical symptoms. Now we talked about what is palliative care. Let's go to the why. Why palliative care? So this is a quote by our dear friend Roop, and he is going to take the end-of-life care session with you. And he says, modern hospitals are like fortresses where the poor can't get in and the rich can't get out. Which is quite true, largely when we look at the private healthcare sector. Okay. And somewhere along the line, we started, instead of calling it healthcare, we call it the health, instead of calling it the healthcare service, we started calling it the healthcare industry. It's happened very subtly, but very significantly, this whole shift. And, but that's very telling of where the value lies now. The value lies in profit. Now, this is the usual model. You have the individual, either rich or poor, and the hospital. Now, just because this person is standing outside, I'm going to assume that this person is from not a very well-off background. But also just remember that practically one of the most marginalized sections of society when it comes to palliative care are the affluent, because a lot of private hospitals do not have a palliative care department, simply because palliative care is not a very profitable, okay? So a lot of people are in high-tech hospitals paying through their teeth, but not getting the kind of symptom control, pain relief, and ability to be close to their families as they want. Now, I'm particularly going to look at the Kerala palliative care model because that is where we are based, and it is one of the more celebrated models across the world. And what it really does is it engages community. Now, going back to the Asthana Declaration, meeting people where they are, when they need it, at an affordable cost and of quality service. And people should be involved in the designing of the healthcare systems that serve them. This is exactly what we are doing, where we're involving the community. And to bridge this gap between this person here and the hospital is the community, because even I also have to, be mindful and respectful of the fact that even at full stretch, our healthcare system cannot take care of everybody's needs. That's where society has to get involved and community has to get involved. Now, I'll just tell you a series of little stories of how this works. Now, typically, where did that picture go? Maybe, let me start with this. What you're seeing here is a link center. Now, so we have the Pallium India Hospital, the Trivandrum Institute of Palliative Sciences, and we have home care teams going out every day, every week, different parts of Trivandrum areas. Now, typically what happens is there is something called a link center. A link center is a public space that is in a particular village or panchayat, and it is typically something like, this is a primary school. It could be a public library or the public space that is utilized by the community there. And so our home care team goes there, and we have a multidisciplinary team. Sorry, my internet connection is a little shaky, but can you hear me okay, Sangi?
Yes, ma'am. The voice is clear. No problem.
All right, great. So, So here you see, people coming to visit, maybe patients and caregivers. They come and collect their medication. They get checked out by the doctor and the nurse, and then they go back. But who are not in this picture? People who can't come there, the sickest of the sick. So that's when we go to them. And sometimes this is what it looks like. Sometimes the path is relatively clear. Sometimes we have to go through places that look like this. And this is Kerala. So this is a sunny day. And that is not something that you see right through the year. And we really have to meet them where they are when they need it. Okay. What you're seeing here is, apart from the medicine, we realize that there's no point in giving out free medication to people when a lot of people are starving, because they have been so impoverished that they have no means of income left. So what you're seeing here is dry rations a month being given to about 100 families that we give food rations to, because that's also palliative care. And I'm going to go back a couple of slides here. Now, what is this young man's story? When he was 19 years old, he had been in a road accident and he had spinal cord trauma and he had some head injuries that left him really not very coherent for some time. And he has one parent, his mother, who's behind him. She's over there. Now, this boy was in the hospital, and after he was discharged from the hospital, he was told, his mother was told to bring him back every week for physiotherapy. Easy, na? Come back once a week for physiotherapy. Fairly straightforward. Now, the problem was that this young man lived with his single parent. She worked in the plantations nearby. She had to be at work from morning to evening, so she would cook him a meal, feed him, and go away, and then come back in the late afternoon. They live in a house which has steps on top of a little hill. The boy can't walk by himself. Then to get to the main road, you have to walk down the steps, walk down the hill, go up another hill, come down, walk another kilometer to the nearest main road. In order for him to make it to that main road, 4 grown men in the village had to take the day off to carry him on a khatia or a stretcher to the main road where there was no bus stop, which meant that the mother had to hire an auto rickshaw both ways, back and forth, which cost her 1 week's salary. So did this guy get his physiotherapy once a week? No. He got his physiotherapy for the first week, maybe. After that, for 3 years, he was in that house, getting more and more depressed, until finally one day, this is what happens. This is how the community works. So people in the community who had been trained in palliative care, basically trained in palliative care means identifying, my neighbor there might benefit from palliative care. My neighbor there might benefit from palliative care. And then what they do is they come and register in the link center and say, listen, next time the home care team comes here, there's another family that needs to be visited. So this was the first time that we visited this young man, and immediately parallel bars were set up. I mean, this is maybe a couple of months later, and physiotherapy happened at home. The doctors and nurses would visit him. And after about, I think, a year or so, this young man is able to walk again. And he started conversing. He got some speech therapy and all of that. So had this boy not been discovered, or his neighbors had not known of palliative care and not known to refer him, he would have probably died in that house. Maybe not from the primary reason why he was in that condition, but from a number of other reasons, depression, so many other things, right? So this is why it's important for the community to get involved, and why this kind of social capital is absolutely necessary. Okay. Let's move forward. This is, of course, Dr. Raj Gopal in one of the patient's homes on a home care visit. And so a lot of people, we talk about dignity, right? We talk about autonomy. For a lot of people, their sense of dignity and autonomy and pride is completely intertwined with how they are able to contribute in the world and to support their families and their role in the community. If I were to ask you today, who are you? What are you going to tell me? Who are you? I'm asking that question right now. Who are you? And you can use the chat box to tell me who you are. How do you introduce yourself when you meet somebody? I'm not talking about going for a job interview. I'm talking about just when you meet somebody, like you're meeting me now. So on a journey. Mostly it's about what you do. Yeah. Mother, daughter, sister, lawyer. So here's the thing, right? The roles that we have, whether they are of personal roles, a parent, a sister, a daughter, or what we do in society. Now, the minute we are diagnosed with a serious illness, what happens? We are a patient. Everybody makes sure that we're a patient, even the people who love us. Because, and unfortunately, I mean, even as an act of love, you know what happens when somebody in your family is not well, you won't even let them get a glass of water for themselves. नहीं नहीं आप रहने दीजिए मैं लाती हूँ. No, 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 don't. I'll do it for you. You just relax. What we're doing is basically turning them into patients even more than they are, right? Because we are taking away their autonomy. And then suddenly everybody has an opinion about your health from your doctor. Doctor, of course, has to have an opinion about your health and your condition, but so does your neighbor. So does your uncle's cousin, cousin-in-law. So does someone who visits you once in, like, once in a week. Everybody has an opinion about what you should do, shouldn't do. You have no sense of being your own person. Your autonomy is taken away and all of that. And also what happens with somebody who has a serious illness, you are no longer able to, you're treated like a bechari. And also, if you're not able to go to work anymore, and if you were the breadwinner of the family, that's a big one, right? You're no longer able to support the family. Now, dignity, autonomy, these are words that we all know are important words. They're words like love. But if I were to ask you, what does love mean to you? What does joy mean to you? You'll all have different answers. Love and joy and dignity and autonomy mean different things to different people. Some people don't mind being taken care of by others. For some people, it's the worst thing to be dependent on other people. Yeah. And for a lot of people, being able to even contribute back in some way is a really big deal. So part of the palliative care services that we do is vocational rehabilitation, enabling people to stay meaningfully engaged in an activity, even if they are homebound or bedbound or wheelchair bound. Okay. And so part of the programs that we run is vocational rehabilitation. So, for example, if a lot of women who have children with congenital anomalies, like cerebral palsy or various other things, they have children with high dependency needs. And sometimes what happens, we've seen it happen a little too often, is that the mother is blamed for giving birth to an imperfect child and she is abandoned. So suddenly you have a young mother, sometimes not very educated, stuck at home with a child who is completely dependent on her, and she probably doesn't have the ability to go out and fend for herself. So something like getting her a sewing machine or getting her involved in a co-op or something goes a long way in allowing her to also fend for herself. Now this man here, I mean, these pictures are all with consent. This man here, he got paraplegia after an accident, so he was bedbound, but the upper half of his body, he was completely agile and everything. So he chose to start making umbrellas. And if you live in Kerala, you always need an umbrella. So it's a fairly, lucrative thing, meaningful thing for him to get involved in. And he was able to, one, keep himself busy, stay meaningfully engaged, and earn something for the family. Dignity and vocational rehabilitation go hand in hand. We don't forget the children, okay? Because even if a child is sick, they still need to be engaged in going back to school and having a childhood, because very young children, it just becomes about the disease. And we also have to pay attention to the siblings of these children, because those children get sidelined and all the attention is on the sick child. And so taking care of children through various programs is a very important part of palliative care. Now, I have mentioned this before today, that sometimes one of the hardest hit areas is the education of the child, because especially in families where they've given up so much, or there's so much financial toxicity, the child will be pulled out of school, the tuition fee will be rerouted and reallocated to treatment cost. then what happens? The illness of one person in one generation has a multi-generational impact on the future of the family. And very often, futile interventions, the person is already way beyond cure. But no, we are doing chemo, we are doing this, we are going in for ICU visits, and more money is being bled out. The family is in debt, and the child will only inherit debt. So one of the ways in which we try and mitigate that is we support children's education. Okay, so I think we have supported the education of over close to 300 children whose families have been ravaged by disease and who have been impoverished. And the beautiful thing here is that, at least that doesn't stop the child from being educated. And at least I think a handful of the students who've gone through this educational program with us have chosen to become nurses and doctors, which is a great way for it to be paid forward. Okay. And of course, we pay attention to the elderly, especially the elderly living alone. And I think COVID taught us a lot about that, because elderly people living alone, and Kerala has something like 176,000 elderly people living alone. And this is an old statistic. Okay, it needs to be updated. And majority of those are women. What happens to them? Even something small like having your blood pressure taken in time, having your sugar level checked. So we have something called a comprehensive geriatric assessment program, where even if the main registered patient is the 40-year-old with cancer, if we go there and we find that the person has two elderly parents living at home, we will quickly do a check of the elderly parents. Do they have mobility issues? Do they have any other issues? Because the last thing we want is for there to be two patients in the same house, and something that we could have prevented. So that's palliative care. Now, I will tell you that the way that I've just described all of these things, very often I'm questioned in other countries, what you're doing is not really palliative care. How much will you involve in it? Because palliative care, when it first started out in the UK, was about symptom control for advanced illnesses, end-of-life care, and hospice. That's the Western idea of palliative care, and that is also what we think about. But in India, like in a lot of low and middle income countries, we do not get adequate care in time at an affordable price. Therefore, more and more people fall under the category of requiring palliative care. People with disabilities, we don't have a separate vertical that will take care of their needs free of cost. People with various other ailments. I've seen many times when overseas exchange programs have happened, and we've had nurses come in from the UK, and I've taken them to the children's unit, and there's a child there with CKD, with chronic kidney disease, who is eligible for a transplant. And the nurses asked me, why is this child in palliative care? Why is this child in palliative care? I'm asking you guys, why is this child in palliative care? Because in any other country, high-income country, that child would not be in palliative care. Why is this child in palliative care? Long queue for transplant is one, yeah? What else? Even when lack of awareness. So one of the most, yeah. So even if the child found a donor, the family can't afford the transplant. So it was shocking to a lot of I would say, I remember this conversation because it happened with some UK nurses. They were shocked that this child was basically in palliative care, going into end-of-life care with us because the family could not afford the transplant. It was a matter of economics. And that is one of the main things that defines what palliative care is in countries like ours versus in the West. So you will read a lot of books about palliative care as practiced by Cecily Saunders, by various other people for whom I have great respect. But please understand that in India and in most low and middle income countries, palliative care has to become a social intervention, not just a medical one. Because here we're looking at the children, we're looking at the spouses, we're looking at the education, we're looking at the vocation, we're looking at community support. It is a social intervention. It is not just about symptom control and end-of-life care. Okay, so you will be asked this question, why is all of this palliative care? This is all palliative care because by definition, global definition, palliative care is the prevention and management of serious health-related suffering. So in India, if you have a serious illness, your suffering is not just physical, your suffering is financial, it is social, it is emotional, it is spiritual, it's all those things. So if palliative care is the mitigation of all of that, then we have to basically come up with interventions that take care of all those things. So yes, it is an extensive field, which is why there is space for all of you to join it, irrespective of your training and backgrounds. Okay, I'm going to change gears a little bit. And we've talked about what we do in Trivandrum. I just want to also mention one thing. The Kerala model of community-based palliative care is considered the gold standard for community-based palliative care in the world, which is great. But it is not the only kind of model there is. I want you all to know that your model of care for your community does not have to be the Kerala model, because every community has its own strengths. A bunch of variables came together, a bunch of moving parts came together in Kerala to make it work in this way. Why is it that since it started, this particular model has not happened anywhere else? Because Mizoram is not Kerala. Madhya Pradesh is not Kerala. So you have to look for strengths within your own communities. So, for example, an interesting thing happened in Mizoram where in a community that is 99% Christian and led by the Presbyterian Church, the church once talked about palliative care on a Wednesday night service, and the entire community took it up. It was something that was led by the faith leaders of that community. And it worked because the community was deeply embedded in that kind of, faith network. Yeah. So soon you will hear of Maharashtra Palliative. Yes, I hope so. So yes, so look for strengths within your own community. The Kerala model is lovely. It's great, but don't look to transfer the Kerala model, look to translate its better points into your own communities, and you will find the strengths. Telangana has a fantastic palliative care model that has rolled out across 33 districts. So, and in other countries, if you look at it, Uganda has a absolutely wonderful nurse-led palliative care system in place. Okay, so I'm just going to, like I said, shift tracks a little bit because we're now going from the local to larger global issues, which I think are extremely important for us to be able to have palliative care in our countries, in our communities. Certain things we have to be aware of, because if you operate only locally with just what is happening here, not paying attention to the larger policies and ecosystem, we're not going to move forward, and we need all of you to participate in it. Okay, so as of today, your first module with us in the foundation program for palliative care, as of now, you have all become advocates for palliative care. There's no two ways about it. As of now, you are all advocates for palliative care. And as we go through all the different sessions, and we go deeper and deeper into what needs to be advocated for, I hope that this is something that will stay with you. Yeah. Firstly, please remember, if you don't have a seat at the table, you're probably on the menu. Why do I say this? Because as lower income countries, we are not part of the decision-making process. WHO, International Narcotics Control Board, all of these are based in global north countries. Their physical headquarters. All decisions about medicines and controlled substances are made in Vienna. Decisions about health are made in Geneva and New York. Most low-income countries don't have diplomatic mission in these places. We go if we are invited. We go if we are sponsored. Our representation at these forums is not adequate. So this is why, this quote has been said by so many people. I don't know who the original source is, but if you don't have a seat at the table, you're probably on the menu. And historically, low-income countries have been on the menu for a very long time. So you need to know where we need to speak up, okay? 68 million people experience serious health-related suffering globally. 68 million, of which 51 million are in low and middle-income countries, of which 7 to 10 million are in India. I'm going to leave that slide on for you to read and absorb. Okay? These are big numbers. And more than 80% of the global population does not have access to pain relief or palliative care. So look at those numbers. 68 million, 51 are in our countries. 80% of the population, global population, does not have access. All of these 80% are in low-income countries, low and middle-income countries. Something is terribly wrong with this picture. This is a great, I'll be sharing it with you via our coordinators. The Lancet Commission report on pain, on alleviating the access abyss in pain relief and palliative care. It's not a small document. It's a rather large one. Dr. Raj Gopal is one of the authors of it. It's a very, very good entry point into understanding global access issues in palliative care. Now, I'm going to take you back a little bit. Okay, we're going to go back to a little bit of Indian history. We all know about the East India Company. We all know how long they were in India and what happened. The East India Company primarily made its wealth on opium. Opium, poppy was grown in Bihar, in Uttar Pradesh. The first, and still only, opium and alkaloid factories in Ghazipur, in Uttar Pradesh. It is the only government-owned factory that takes raw opium and extracts the alkaloids to make morphine sulfate, which then gets converted into codeine and morphine and everything else. All of this started under the, in India historically did grow opium, but in small quantities, not as a drug, more as medicine. It was commodified under the British and the Dutch, and after a while, it became what fueled empire. The entire empire was built on it, and so much so that when China didn't want any more opium brought into its country, Britain went to war with China, and that's how the Opium Wars happened. If you read, there's a lot of really interesting books. There's Amitav Ghosh's Smoke and Ashes. It's a great book. There's another book called Opium Incorporated by Thomas Manuel. Please read this. It will change your perception of Indian history. And so the British Empire was built on opium, on the opium trade. Okay, but after the war, after the World War was over, and a lot of the colonies left, erstwhile colonies, because they couldn't afford to be colonialists over there anymore. What happened is they went back, and then after the Second World War, this whole war on drugs rhetoric started. That's also a very convoluted thing. I'm not going to get into the details of it. But what emerged from that was a sense of control. We have to control drugs. We have to control access to it. So what came after the colonial opium trade was the drug control treaties of 1961, 1974, 72, and 1988. I'll tell you just a little bit about it as we go ahead. The drug control treaties, what they did was they said, no, we have to regulate all production, cultivation, supply of all these drugs, opium and cannabis and all that. And who's going to be responsible for regulating it? All the countries that are growing it. So effectively, I'm a British East India Company person. I've made lots of money on opium and I've left. And now after I've left, I'm telling you, you can't make money on it. We're regulating it. It's neocolonialism, okay? And they use the war on drugs rhetoric to justify it. And it's only in the 21st century, in the last, since the 60s and 70s, that we really started talking about palliative care and medicine. So this is the history of the commodity that is responsible for pain relief and pain management, which is morphine derived from opium. And it's a very interesting history. It's been vilified by a lot of people, but there's no denying the fact that we have a very rich history with opium, and we need to be able to understand it before we start, outright, having just binary opinions about it. Now, I'm just going to explain a little bit further what I mean by that. The 1961 convention at the United Nations, basically, almost every country signed on to it. And they agreed that we have a dual responsibility. Now, I'm only talking about opioids. to prevent the abuse of controlled substances. So abuse, misuse, diversion. And so we don't use the word abuse. We say misuse and diversion of controlled substances, but equally to make controlled substances available for medical and scientific purpose. Now, for example, from the opium plant comes morphine and comes heroin. Okay, so there are various controlled substances which can be used for medical purposes, but also can be used in harmful ways if they're used, recreationally or excessively or whatever. So basically, the single convention is saying that no, we're going to make sure that those that have medical purpose, we have to make it available as well as prevent the misuse of it. Sounds perfect. It's what we call the principle of balance. And that is what we aspire to. We prevent the diversion and illicit use, and at the same time, we make it available for medical and scientific purpose. This is what the snapshot should look like. But this is what it looks like. Across the world, the bigger focus is on prevention of diversion for illicit use. Case in point, all of you remember, let me bring this home again. Shah Rukh Khan's son got caught a couple of years ago. Aryan Khan. What was the act under which he was caught? Does anyone remember? Yeah, I'll give the names of the books and authors. Okay. So does anyone remember the act under which he was caught? Narcotic drugs and psychotropic substances. Yes. Okay. Yeah. Yeah, they said he had drugs with him, but NDPS, yeah, narcotic drugs and psychotropic substances. Okay. And everybody heard about the Narcotic Drugs and Psychotropic Substances Act. Okay. The NDPS Act came into being in 1985. Now, what the war on drugs rhetoric that started from the Western countries, what happened from there was that countries around the world started bringing into place extremely restrictive drug-related laws, which were very, very hard on with punishment. And that's exactly the law that was exactly the act that was enlivened during this case, right? So even possession of a drug, etc., will put you in jail for 10 years without bail. It's that kind of punitive a punitive law. Now, so why am I telling you about this? Because what impact does it have on palliative care? The Narcotic Drugs and Psychotropic Substances Act of India, which came into being, I'll just very quickly, before I go into that, I want you to look at this map, okay? It looks like a very awkward map, right? Some of us in international advocacy, we call it the cartography of pain. It's the map of pain in the world, because what it's really showing us is the access to pain relief in different parts of the world. Are you able to see it? Sangeet, are you able to hear me? Okay, fine.
Yes, ma'am. Yes, ma'am.
Okay. Now, this map tells us the percentage of need met for pain relief. We all know about the opioid crisis in North America. So North America is bloated. So is Australia. The only sort of region in the world that seems to be okay-ish is Western Europe. Every other country in the world has practically disappeared off the map. This is a map of access to pain relief. And if you look at it, all the countries that have disappeared are erstwhile colonies. Now, this is again showing you the gross inequity in access to pain relief in our world today. Now, coming back to the NDPS, as a response to this war on drug rhetoric, like I said, countries came up with various laws. India came up with the NDPS Act of 1985. And once it came in 1985, 716 kgs of morphine had been used. But suddenly this law comes in, and this law is terrifying because it's saying if you are found, in possession or in possession of even a little bit of extra controlled substance that is listed under this, etc., offense, blah, blah, blah. Doctors got scared. They stopped prescribing it. And there was this opiophobia that came in. And by 1997, there was a 97% drop in pain relief in India, which meant that the pain burden in the country went up that much more. So what does this law do? Effectively, this law has become the biggest barrier to pain relief in our country. So many people in the palliative care, amongst the pioneers of palliative care, including Dr. Raj, Dr. Nagesh Simha, and various others, got together and they petitioned, they advocated for the law to be changed. It took us 19 years to get this law changed so that people in India could have access to morphine. And remember, India is the largest grower of legal opium in the world for the pharmaceutical industry. And less than 1% of our population was getting access to pain relief for cancer pain. Now, I mean, according to some statistics, we're at 4%, but we have a long way to go. So what I'm trying to tell you is that even our own laws can be extremely, they can become barriers to access to pain relief. And we need to understand these things. We can't say that I'm not interested in the legal aspect of it, because this actually governs if tomorrow you're in the hospital or you're at home and you need immediate release oral morphine to alleviate your pain or your breathlessness. These are some of the barriers that are going to be in place. Okay. Now, how does all of this cerebral stuff translate to the layperson? This man with cancer pain spent most of 3 weeks in this position. He couldn't even sit up. He was in so much pain. He asked us for euthanasia. And 3 rupees worth of medicines, that is immediate release oral morphine, enabled him to sit up and have a cup of tea for the first time in 3 weeks. And he retracted his euthanasia request. This is why access to medicine, affordable medicine, is so important, because it has a deep impact on not just, it's not just about the pain, it's about your ability to be a human being and engage with your life. Okay. Now, again, I'm just going to go into this. The principle of balance. When we talk about principle of balance, we're trying to balance control and access. We're talking about, no, there's harm. People shouldn't have access to drugs, and then people should value having access to healthcare. And it's always this debate. And continually, we find people taking sides and saying, no, I don't want my child to get into drugs. No, I don't want this to happen. But here's the thing, in this line of work, we really need to refocus our lens and pay attention to the fact that the balance comes when we take a patient-centric approach. What does the patient need? Whether the patient has a substance use disorder or the patient has cancer pain. What is important to this person? And how can we mitigate their suffering? People who have substance use disorders are also suffering. And we need to consider that. So what does this patient-centric approach look like? Focus on the suffering of the individual and the families. This person is not getting access to palliative care or pain relief. What can we do to improve it? We need to focus as professionals, as advocates, on safe access. And for that, we have to have high quality data on opioid use outcomes. We have to work with doctors and we have to show evidence that, see, giving morphine to somebody does not hasten death. Giving someone to morphine does not lead to addiction. Giving morphine to somebody does not have all of these things that people are worried about. And we need to generate evidence for it. It cannot just be anecdotal. And finally, we cannot do it alone. NGOs cannot do it alone. Professionals cannot do it alone, and the government cannot do it alone. We all have to work together. And wherever the model of palliative care has really worked, whether it's in Kerala or in Telangana or in other parts of the world, partnership between the government, professional, and civil society, that is NGOs, has been the winning formula. So you are part of civil society. You may not be a doctor, you may not be a lawyer, but you are part of civil society. And for any one of us who is engaged or interested in palliative care, we have to look at this as a collaborative and not as a confrontational space. Okay, so I'm just going to play a video for you now, and I'm going to start closing down the session. I really hope my bandwidth allows it. Arya, do you have the video? Care Association. But that was actually one of the nicest depictions of palliative care where community gets involved and it's an interdisciplinary approach. So I'm going to stop with that. I know we have a few extra minutes. So I will invite you all to ask questions, share reflections, and the Pallium technical team probably is in shock because I rarely ever end this early. But Yeah, I'm happy to take any questions. If there's anything in particular that didn't, then please go ahead. Oh, Dhvani, that's a very difficult question. Childbirth. Can you tell me a little bit more about what you mean?
Can I just speak directly? Is that okay?
That's better actually. Yeah.
Okay,
Thank you.
great. Sorry. No, I just meant that does providing pain relief during childbirth, is that seen as a part of gynecological or reproductive care, or is it seen as part of palliative care?
That is such a great question, and I'm going to actually have to ask our medical team. I don't think I've ever heard it personally. I've never heard it being brought into palliative care, but I think it's supposed to be part of the reproductive health sort of team.
Sure.
But I know that neonatal pain management is an up and coming field.
Right.
And
Okay.
and I think that's a very difficult one because it's the
Exactly.
parameters are quite different. But so I know there's a lot of new evidence building happening around that. But this particular question of yours, I'll definitely check with some of the
Sure.
seniors and I'll get back to you. Thanks.
Sure. Thank you.
Interesting question. Yeah, Shanmugapriya.
Session.
Huh.
Thanks very much. The thing is, I'm for the past 5 months, I'm into palliative care now. A very nervous way for me. I was very naive about palliative care, and past 5 months I've been to Pallium, India, and now I'm in Madurai, where I don't see any comprehensive palliative care. Mostly it is pain management under the anesthesiology department. And I face frustration like wherever I go and talk about it to start a unit in the hospitals or anywhere, I don't get a welcoming attitude. So Dr. Raj and suggested that why don't I start my own services? So if I have to do that, what is the first step I have to take? I'm ready to do that and I'm ready to dive in. But if it is an extensive answer, I can get back to you. But if it can be
So the good news is that your next session is entirely about answering this question of yours. How do you organize a palliative care service, and who is part of the interdisciplinary team? And so we have 1 hour of just having that one question answered. I will say that we have certain roadmaps in terms of documents, SOPs, dockets that we can share with you, because also just to know, I think it's important to know the distance you want to go, who you want to serve, and then sort of build the blocks towards it. And we have certain roadmaps that we can share with you that you can then apply in the context that you're working in. And well, we do have a facilitation team as well, and we have regional facilitators for the South. We have people taking care of Tamil Nadu, Karnataka, etc. So they will be able to handhold you through various of the more policy-related stuff, as well as when it's time for you to get a recognized medical institution license so that you can, also stock and dispense opioids and things. So happy to provide the technical support offline as well as in the next session. And the whole team is available to you to talk you through that whole process. Yeah, but thank you. And I find that with a lot of champions coming into the field, it is quite intimidating at first. But it's I'm so glad that you don't sound daunted and deterred. So so I'm sure that in the next by the next year we'll hear of your center, and we'll be happy to collaborate with you as well. Are there any more questions?
Hi, madam. One question. So this palliative is applicable for mental illness as well, right? In the verge where somebody is living alone and they have some mental issues, but they are not aware of it. How do you, is that how it is, or they should seek a doctor help, or can it be? I don't know. So just asking on the mental.
Yeah.
things.
So I trained as a psychologist, and when I first got into palliative care, my sole, I mean, I thought the direction I wanted to go in was to provide emotional and mental health support to families. Palliative care, the way I've experienced it, is an evolving field. It's a very fluid field, even now as we speak. So a lot of what we're doing is coming from collaborating with other experts. So far, we've seen social workers and volunteers and all that in the team. It's only recently that we've started seeing psychologists becoming a part of palliative care teams. There are I can think of only 2 psychiatrists in the country who work with palliative care. So it is not integrated, not to the extent that you and I would probably want it to. But there are organizations, but there is a considerable overlap. So not to say that, if it's a person living with schizophrenia, we're absolutely not going to go in there, but we will need a psychiatrist on our team, or at least a consulting psychiatrist, to help us navigate that space, because there are still areas of expertise that, we will need to lean on the experts themselves. Going forward, I'd say, Sarita, that I would like to see nothing. I mean, nothing would make me happier than to see a well-integrated mental health, psychiatric, psychological, and physical team working together. Now we've started integrating it with physiatry and physiotherapy, which is great. We've now started integrating with neurology. In fact, I mean, at the risk of sounding like a fangirl, but Dr. Roop and various others are now leading the charge for neuropalliative care. Till recently, palliative care was seen as something for people with cancer and people with really advanced conditions, but we did not know how to do palliative care with people who have dementia or Alzheimer's or ALS. But now that field is emerging. So I'd like to believe that with mental health also that's happening. We are in conversation with organizations like the Banyan in Madras, Academy for Leadership in Mental Health, because we're trying to co-create modules that will allow better training of people. Because even if you're a doctor, you need to be able to deal with, some of the mental health issues that families go through. And illness is a very triggering time, I think, for families, right? So if the coping mechanisms were bad to begin with, they only get worse when a crisis hits. So long answer, not even an answer, but long response to your question, not fully integrated. It should be in the realm of palliative care, but we aren't there yet. And yeah, but thank you for asking that question.
Hi, ma'am. Hi. If you could talk about firstly, thank you for the session, and if you could talk about the ambiguity that is involved when it comes to the when of palliative care, like when does it start? And because there's no clear, especially in the clinical aspect of things, when there is no written prognosis or a diagnosis that says that the palliative care should start from now. So when do we know? And that when part is because there's a lot of overlaps, there's a lot of ambiguity, there's a lot of duplication of services that is happening, invisibilization is happening. So how do we know that? So how does that happen? And second, they say that the data is the new oil, and with so many organizations working in healthcare today, especially those wanting to work in palliative care, how do you? And we also talk about decolonization of things, but still there are no SOPs in place. There are no metrics, performance metrics in place. How do you document these things? Things like that. It's a thanks. Thank you.
So 3 parts to your question. One is when you refer, it's on a case-to-case basis, Parag. Unfortunately, like I said, the biggest challenge really comes, I think, like someone said, from within the medical fraternity. Okay, so you can convince the policymakers, you can convince lay people. It's been a tremendously uphill battle to convince the medical fraternity to then now make the referral to palliative care. Like I mentioned, it's only come into the medical curriculum as recently as 2019. So we're talking about a generational shift. I can't anticipate that will happen in the next 5 years. Having said that, I mean, it's not all bleak, because several specialties are now also, they're opening up to the idea that palliative, for example, one of the big breakthroughs has been that the Indian Society for Critical Care Medicine and the Indian Association for Palliative Care have put out a joint statement. You would think that people in critical care settings and palliative care settings would be at loggerheads, but now we're actually talking to one another. And we're talking about things like, okay, if a person has been in the ICU for 7 days, they should have a mandatory palliative care consult. Because why should somebody like some doctors will say that an ICU that has a patient for more than a week is a bad ICU, right? So that evolution is very slowly but surely taking place. I would say, bring the onus back to educating folks around you. Palliative care, like I said, has a place right from the start. You don't have to be in excruciating pain to access palliative care. And unfortunately, I've heard that too many times. Someone will call me from Bombay and say, I'm in so much pain. And the doctor says, it's not yet time to start you on morphine. So how much suffering do you have to endure before you become eligible for palliative care? That's stupid, in my opinion. And they will call us and say, can you tell us of a palliative care service in Bombay? I'll tell them the name of a palliative care service that exists in the same hospital that they've been getting treated at. And the doctor will not refer them to the next floor to the palliative care unit. So I haven't answered your question. What is the right time? I would say from the time of diagnosis. It's important to have conversations about, like Dhwani is here. She's one of the architects of the advanced medical directives in India. We talk about when should we have that conversation about, what kind of care I would need if I'm really sick. You should have that conversation when you're healthy. You can't have that conversation in the ICU when you're already, on your way to getting on the ventilator. So conversations about what is of value to you. Start having those conversations now with your family before you get sick. Acha, if I should get sick, then these are things that I don't want. These are things that I prefer not to have. I don't want extensive chemotherapy if I've been diagnosed at a late stage cancer. Because it's only when you're cool-headed that you can have this conversation in a way that is reasonable and making sense to you and your family. Otherwise, it's a volatile conversation. So even though we have a session on end-of-life care, what I will also share through our coordinating team is our advanced care planning and advanced medical directives toolkit that gives you, that whole roadmap of how to have these conversations within your own family. Because once illness comes in the picture, every decision the family is making is an emotional decision. Yeah. So I hope I've answered that. The second question that I think you asked was about, not being any SOPs around decolonization and stuff. No, we're picking up the vocabulary of decolonization now. It's only now that we're sitting around and having a conversation saying, hey, what works for the West does not necessarily work for us. So no, there are no SOPs. However, we were part of a group that created assessment and monitoring indicators for palliative care services in the world, in member states around the world, and it gives you a number of indicators that you can measure to see what level of service your country is at. You can also distill it down to a more local level. I will tell you, Parag, that there were so few of us on that table that we really had to fight for certain output indicators to say, initially it was like, okay, you have to tick these boxes. You have a law in your country. You have a national program for palliative care. You have this, check this box. If you tick that box, you think, wow, this country has made great progress. But the fact of the matter is, the law can be in place. Who's going to implement it? The NDPS Act was amended in 2014. It's now 10 years later. And some of our regional facilitators are sitting here, they'll tell you, majority of the states in India have not amended their law. So for countries like us, the real indicators are, has this law actually been put into place? So the best I can offer you close to an SOP is that indicators document, which I will share through our coordination team. And I think I'm going to get a scolding from the technical team if I don't keep quiet now. So any other questions that you might have, please do root it. I will warn you though that you're going to see a lot of me because I'm going to be taking many more sessions with you. So we can keep having this conversation, and I'm happy to share whatever resources and learnings and literature that we have with all of you. So I'll keep quiet now. Thank you all very much for attending. I hope the first session of your FCPC will encourage you to come back regularly for all the sessions. And back to you, Sangeet and Arya. Thank you very much.
Thank you, ma'am. First of all, I should thank you because in the beginning, I know there was a problem of internet connectivity, but you managed really well, ma'am. It was a very nice experience listening to you. Even as a coordinator, it was a very good experience for me. I am sure that participants could gather much information from your session. The second thing is that the session was really interactive. That is because the participants were so interested in the topic and they interacted really well. They were very active. So keep on doing that in the coming sessions also. I'm thanking each and every one of you for the attentive and interactive participation. I thank you. We'll see you in the next session. Thank you. Thank you so much.